So I think we could probably just go ahead and have it recorded and people can watch it later if they can't today. So I think you just have to find your, yep, I think that, yep, try slide 9. That's the question. And then the next slide is the actual slide. So 77-year-old female undergoing biopsy of renal mass differential diagnosis. So you have to go to the next one to actually get the full. Yeah, perfect.
Okay, this was obviously kidney biopsy. And as you can see, this is normal or not so normal kidney, as a matter of fact. Lots of sclerosed glomeruli and tubules. And until we come to the end of this biopsy, where you see this mass or unusual finding, which obviously doesn't look the same as the rest of the normal kidney. This part is composed of mostly tubules that are kind of squeezed and elongated. And maybe in some areas, there is a hint of maybe papillary architecture, although that's really like maybe in here. Although most of this mass is actually made up of tubules, somewhat compressed and elongated. When we go to look at the cells itself, it seems that cells have mostly clear to granular cytoplasm, and the nuclei are located at the top of the cell rather than at the bottom. And somewhat the tubules have appearance of almost like secretory endometrium. Obviously, the nuclei are small. There are no prominent nucleoli. Obviously, something in a low-grade category of tumors. Now, differential diagnosis obviously is something with clear cell and something with papillary structures. Therefore, we are talking about clear cell RCC, translocation RCC, clear cell papillary RCC type 1, and so on and so on. In this specific, when you really look at the disc, clear cell is less likely because you don't have this very rich capillary network. And which would be typical for clear cell. Therefore, clear cell in this situation is less likely. Papillary RCC could be in this differential, although there's no really good papillae, and there are no macrophages. There's nothing like that. Translocation RCC, as you know, can look like anything. Therefore, we need to keep in mind that translocation RCC, especially with certain partner genes, can look like this. And then, of course, clear cell papillary is the one that you have to think about, especially because of these tubules and the arrangement of nuclei and so on and so on. I think the next one is immunostain. I'm not sure, I don't see the label which stain, but we can look at it because there are certainly two specific stains. CK7 is one of them. This one is very strongly diffusely positive.
If you click on the little eye, it'll tell you which stain it is on the top left.
Where is I?
All the way to the left.
All the way to the left.
There. next to reorder.
Next to you.
Yeah, the little I.
Oh,
That
okay.
guy. Oops, CJ. Yeah, CJ.
It's CK7. I kind of recognize this
Yeah.
thing because it's strongly and diffusely positive. This would be very, very, very unusual for clear cell and translocation RCC. Therefore, we are already less likely to think about these two entities. Therefore, we are thinking more about papillary RCC type 1 because it's low grade and so on and so on. And of course, clear cell papillary, which is diffusely positive for CK7. And the next stain, let me see, again, this is okay. The next stain should actually clinch the diagnosis because this is a CA9. CA9 is the stain that should be diffusely positive in clear cell papillary, and it's also diffusely positive in a specific manner. In here you can see that it's a cup-shaped stain. If this was a clear cell, it would be box-like. And of course, in papillary RCC type 1, this would be negative stain. Therefore, based on the morphology and immunohistochemical staining, we eliminated clear cell, we eliminated translocation RCC, and we eliminated papillary type 1. Therefore, the final diagnosis is clear cell papillary. And it looks like I have one more stain. I think I remember what it is. This stain is GATA3. 75% of clear cell papillary RCCs are positive for GATA3. And in here you can see it's a beautiful nuclear stain, GATA3. There's only one more RCC that stains with GATA3 that is recently described, and it's a papillary with inverse polarity, and it has RAS mutation. Therefore, that's another one that stains with GATA3, but that one wouldn't be positive for CA9. Therefore, we have clear cell papillary staining for diffusely for CK7, nice cup-shaped CA9, and GATA3 with morphology and this immunohistochemical profile. That's the diagnosis. Okay. Any questions, comments?
Can you check the, let me check the chat. There's a, oh. Here, let me grab it. Chat says, how can we get to the answers we put down during the quiz? Oh, I don't think you can access your own answers once you submit it, but I can send them to you because I have them all saved.
Thank you. A few of us are wondering, you know, and just to compare and see what we could.
Yeah.
Thank you.
Any questions for me?
Actually, if I could ask Tatiana,
You
I
have
thought
one
I
more
saw some
case.
macrophages in there.
Sorry?
I thought I saw macrophages in the stroma, you know, in that papillary component that was at the beginning of the not right at the tip of the slide, but where there was the junction between the normal and the first tumor started. There were definitely some macrophages in the stroma, I thought.
I mean, oh, is this me? Macrophages are not specific for any RCC. We usually see them in a fibrovascular course in a papillary type 1, but
Yes.
Macrophages can be seen in any RCC. Therefore, they are not very specific.
Okay. Yeah, in the bottom left, that you know that stroma and by that sort of empty blood vessel in the middle. If you go, go higher, right here, not there. Yeah, it's right there. There, see, in the lower part of,
Here,
yeah. Don't you think those are macrophages in the stroma?
I see some plasma cells, but I'm not 100% sure.
Okay.
I see macrophages.
Okay,
But nevertheless,
but you're right. Nevertheless, there are only a few if there are any, right? Okay, fine.
Not
I just want,
yeah. Mhm.
sure.
What is next, case?
Keep scrolling. It should be the prostate. There it is. Slide. Yes. This is a guy with a prostate biopsy.
Mhm.
And then next slide is the full slide
Okay.
with your stains.
Okay. This is obviously prostate biopsy. We see nice core. And as I always point out, when you are looking prostate biopsy, you actually tend to do that on a low power, trying to assess, is the architecture normal, which means there are groups of glands that are forming almost like a lobular structure, and then there's enough stroma in between. Of course, most of these are from peripheral zone, and many of those are atrophic, just because men in this age tend to have BPH, and the BPH nodules are compressing the rest of the peripheral zone and causing atrophy. But if you look at in here, you see nicely organized lobules of glands, even though some of them are obviously atrophic. You can see the shapes are irregular, which is typical for atrophy. And there is a very thin, there's actually attenuated layer of epithelial cells. This, on the other hand, looks like more normal gland with normal amount of cytoplasm and normal nuclei. Once you assess the architecture in biopsy, and there's a little bit more of this lobular architecture in atrophic glands. When you assess the architecture, then you go to the area that doesn't quite fit that normal appearance of benign prostate. In here, of course, you should recognize the structure that you are dealing with. Obviously, these cells are quite big. They have abundant cytoplasm, which is mostly granular, and the nuclei are big with prominent nucleoli, and there is also this pigmented granularity. And these big cells are somewhat embedded in this stroma with spindle cells. Nevertheless, the structure is organized. It has this rounded, organized appearance with these cells embedded in the stroma with spindle cells. In addition to that, we have obviously glands. There are two glands. However, when we look at the glands, it seems that they appear normal. They have multiple layers, and the nuclei are relatively small, maybe some hint of little bit of nucleoli, but morphologically, cytomorphologically look quite bland. Now, the structure, obviously, it's a ganglion, and then the glands are embedded within. Of course, the teaching is that you have, when you have glands within the ganglion or next to it, that immediately means something is malignant. However, in this case, you need to judge morphology rather than the location. And this is actually, let me see, my next.
Can I have the mouse back for a second?
Okay.
There's a weird thing in my screen. I need to get rid of it. That, you know, that little copath like
Okay.
thingy. All right. Okay, go ahead. Thanks.
Okay, the next slide should actually have, let's see what this stain. Okay, this is a pin 4 stain. And just to confirm that all these previous glands in the nice lobules are all benign. As you can see, they all have basal layer. Now we have to go to this structure here. And you can see that in this area, the basal layer is also preserved. I know that some of you have always these questions about what if one gland is negative and the rest has staining. Again, when you have atrophic glands, the basal cell layer is not continuous. As you know, it's very random. You can have one gland with one basal cell, one with none, one with 3 or 5. Therefore, you have to decide if all glands look the same. If they all look the same morphologically and you have some basal layer, these glands are benign, okay? Therefore, in this case, we have atrophic glands that are next to the ganglion or within the ganglion, but obviously they have basal cell layer and they are benign glands. Therefore, morphology with immunohistochemistry rules rather than location. And let's see what is the last one. It's probably S100, yeah. Okay, the last stain is actually just to confirm that we are dealing with the ganglion. And this is beautifully positive, as you can see. Especially stromal cells. And you can see how nicely organized this structure is. And then you see embedded glands within. Therefore, again, cytomorphology rules, number 1, with addition of immunohistochemical stains to confirm. And then location is not defining moment for this kind of situation. Yeah, you cannot call things malignant just because they're next to the nerve. And as you know, I think some of my colleagues are here from GI. I know that like in the pancreas, you can have benign islet cells next to the nerves also, or around the nerves. Therefore, be careful calling something malignant just because of that. This was just signed as benign prostatic tissue.
So Dr. Antich, would you think that this is something like just displaced during the biopsy, or?
No, I know for sure because I look at prostates all the time. Very often we see benign prostatic glands next to the nerves.
Okay.
And ganglion cells. Therefore, that's a normal finding.
Okay.
Any other questions?
The chat just says, how was it signed out as, yeah, just benign prostatic tissue, and no, not pathological, just normal.
Okay. Thank you.
Thank you. Okay, who wants to go? The Dr. Hussain, you
It's
asked?
okay, I'm still here. It'll work out. Just go in order.
Okay, who has, who wants to go next then? Case number 1?
Oh, sure, I can go.
Yeah.
Yeah.
So,
Start one. You mean, okay. So my case was a 33-year-old male who had ulcerative colitis on immunosuppression and presented with fevers, abdominal pain, and rectal perforation, and he underwent a total proctocolectomy. And the questions, what's your diagnosis or differential diagnosis, and what special stains would you order? So when you look at the slide here, so this was a section, I think, from his ascending colon or cecum. And obviously on low power, it looks very abnormal. It looks like the mucosa is, oh, do I need to share my screen so that you can see me point to stuff or no? I guess it doesn't matter.
No, you could,
Um,
it's up to you.
so on this section in the bottom, you see the mucosa on the left, and then it's just absent in the middle. So it's a big area of ulceration, and you see the same thing in the top piece. And additionally, you see that the wall looks very inflamed. If you look a little closer at the background mucosa, you can see that it looks pretty normal. It doesn't have much architectural distortion or inflammation. So it doesn't really look like there's inflammatory bowel disease in the background in these sections. And now I'm telling you, this is the ascending colon. So that kind of would make sense, or is compatible with his diagnosis of ulcerative colitis, because it could just be involving the more distal portion of the colon. But then when you look at this area here where there's the big ulcer and this transmural inflammation, you start seeing that there are actually a lot of granulomas in the wall here. And as you move around, you can also see that there's quite a bit of necrosis. Some of it is associated with the area of ulceration, so maybe you think that it's just related to that. But even deeper in the wall, in these areas down here, yeah, like next to this vessel here, you can also see that there's a lot of necrosis here with this granuloma, this inflammation around it. So obviously you're seeing something that's not exactly typical for ulcerative colitis, because you have a lot of granulomas. You might think, oh, there's granulomas associated with the lymphatics, and it's Crohn's lymphadenitis, but that would be unusual to have necrosis associated with Crohn's granulomas. So you always want to think of infections if you see necrotizing granulomatous inflammation in any case, but including in a case that's labeled as IBD. And if you go to high power in some of these areas of necrosis, a little hard to see for me here, but you get the sense that maybe there are these kind of cleared out little rounded structures in these necrotic areas. It was easier to see on the real glass slides, but obviously you want to do bug stains in these cases. And in particular, if you see those kind of rounded, cleared out organisms, you want to do a GMS or a PAS to look for fungi. And I also would get an AFB to rule out mycobacterial organisms. And here's the GMS stain. And you can see if you go to that same vessel, this necrotic area where we were seeing those organisms or those structures that we suspected could be yeast, you do indeed see these clusters of small uniform yeast. They have somewhat tapered ends on one side, and there is also you could see some narrow base budding. Let me see if I find an area with, maybe here, I don't think I can point, so I guess you'll just have to look at it and decide for yourself. But I think there was some narrow base budding. So these structures were consistent with histoplasma, and then this patient was also worked up clinically and was found to have histoplasma antigen positivity as well. So he had developed disseminated histoplasmosis involving the colon and his small bowel. And that was in the setting of being on immunosuppression for ulcerative colitis, which is not that common, but we did see in the rectum, which you didn't see in this section, but in the rectum there was ulcerative colitis in the background. So I think probably he did have ulcerative colitis initially, and then when he was put on immunosuppression, he probably his histoplasma that was, he was able to he was able to suppress it. It became disseminated, and he developed this complication. And then he was treated with amphotericin and itraconazole, and now he's doing fine. So fortunately, he had to have his colon out, but that might have also happened even if he just had ulcerative colitis. So in the end, it worked out okay, I guess, but it was a pretty severe presentation. And obviously a rectal perforation in ulcerative colitis, it makes you very suspicious of something else going on, because ulcerative colitis should be a superficial process involving the mucosa, and it shouldn't be causing perforations unless they have like a kind of megacolon with a lot of dilation. So that was a cool case.
That must be really rare to have histo in the colon. I don't know that I've ever heard of it.
I have seen histo in the colon before, but it was in AIDS patient.
So in the immunosuppressive setting, you can
Yeah,
see.
so it really only occurs in immunocompromised patients. As you know, it's the organisms are usually within histiocytes or
Yes.
within these areas of necrosis. So usually in the mucosal biopsies, you'll see a lot of histiocytes in the lamina propria in patients who have it. And that's always you always want to work that up with bug stains too. But yeah, I've never seen another case where they had like transmural involvement with perforation. I think that is pretty unusual, and I'm not exactly sure why he developed it, because obviously we see a lot of patients who are on these medications and live in these endemic areas who don't develop disseminated histoplasmosis.
Mm-hmm. Yeah. So was the mucosa involved also? I mean, could this have been diagnosed on a biopsy?
So it was very ulcerated. There weren't really like aggregates of histiocytes in the mucosa anywhere. It was always in these like very ulcerated areas. So I doubt it could have been diagnosed on the biopsy unless you were lucky and they biopsied an ulcer and it happened to be there, but it would have been very hard to diagnose on the biopsies. Yeah, the area that looked like ulcerative colitis didn't really have these changes in it. So.
Okay.
And also, as I said, it's involving the small bowel. So that was another clue that this wasn't just ulcerative colitis, because that should be confined to the colon.
Was there any clinical test, like antigen test or anything that was done that might have pointed towards this diagnosis?
After we got the resection, they did do a urine antigen test, and it was positive. But initially, they didn't know that this was the diagnosis. So they kind of used that to confirm this was histoplasma, because we called it consistent with histoplasma, but
rather than the other way around, sort of.
Yeah. Clinically, they didn't know what it was. I think when they brought the colon to the gross room and all the clinicians came to see it and they were trying to figure it out, I think then it was raised that this could be like an infectious condition, maybe fungal. And that's when they started kind of working him up. But when they were kind of waiting for us to tell them what it was.
I'm just kind of asking this, sorry to take up time, because it seems like it might be a good opportunity for, pathology to save the day type of thing, where we could raise like, hey, maybe you should consider these antigen testing, in patients where it's questionable what it is. Maybe it hasn't crossed your mind before, if we have to take out the colon, we'll take it, but maybe if we can find the diagnosis prior to taking out the colon, it can be helpful. Who knows? I don't know.
Yeah, I guess if they had been able to work him up before he perforated, but unfortunately when he presented here, he was perforated, so they didn't really have much of a choice anyway.
Yeah, okay.
Thank you. Who would like to go next?
I guess I'll go then. What was my case?
Um,
Can you drive and read the story, please?
what'd you say?
Could you drive also and read the story?
Oh yeah, do you want me to drive or do you want to drive?
Yes, no, I'm on my phone, so I cannot
Oh,
drive.
okay, okay. So this is an 80-year-old male with bilateral lung nodule undergoing VATS wedge resection, differential diagnosis and or stains.
Okay. So as you can see, here is a nodule. The lung parenchyma in the background looks like it has some emphysema. And then the patches of fibrosis, as you can see at low power. If you go higher power, are there granulomas? Or what is going on? So not that I
There's a
remember this. Okay,
big
there.
sea of
So there's pink, yeah. So you can see pink amorphous material. And at the periphery, there are some cells. So you do have to decide on what the amorphous material is first. The way it looks with no structure, nothing else, you would think this is amyloid. And then, oh, there is some bone formation with it, calcifications, which are quite often seen in these nodules of amyloid, as well as giant cells at the periphery, which are trying to eat up with it. Giant cells are also very common in nodular amyloid. So when amyloid involves the lung, it has two distinct patterns. You can get these nodules, or you can get interstitial involvement in the alveolar septa and around blood vessels. So when you're looking at the nodules, the thing you have to remember is calcification is common, giant cells are common, and then you do have to look at those cells to see what's in there. What are those cellular infiltrates? And here, as you come closer, there are some lymphocytes as well as plasma cells. So yeah, great, thanks. So when you have that many plasma cells at the periphery of the nodule, you have to think about a patient that has multiple nodules, whether there is a plasma cell monoclonal, are they monoclonal or not? So you should be ordering, so the stains that you would order, so your on H&E, your diagnosis should be amyloid. That should be straightforward enough. And then the fact that there are multiple nodules as well as there are plasma cells, you should order from clonality at least a kappa lambda. And I think this patient did have myeloma in the lung, involving the lung, and the amyloid was associated with it. So I think we gave full credit for people who said at least recognized the amyloid and said they would do a Congo ride. And then those that ordered kappa lambda got a bonus half point.
I don't think anybody did.
Oh, nobody did? Oh, okay, but that takes care of our bonus.
Nobody
then.
ordered Kappa.
You know, I was talking to Tony about the Kappa Lambda business, and he
Yeah.
said they are not very good. And like I usually send all amyloid to Mayo for typing
Yes, we do too.
because he said the stains are not very good.
Now, yeah. So all the cardiac amyloids and all of those go to for typing, but this one, since there are so many plasma cells, you do need to establish clonality. So you can do, I guess, in situ hybridization for it, and that is much more specific. We're not doing the stain for the amyloid typing, we're just doing the stain for the plasma cells. So the plasma cells will do stain really well with it.
Okay.
Okay.
If it's okay with you, maybe I'll just go to your next case. You can get
Yes,
both of
please.
yours out of the way.
Great, thank you.
Why to Kappa lambda when there is no plasmacytosis here?
There were plasma cell infiltrates at the periphery.
Yeah, I mean, I think any amount of, inflammatory cell component at the periphery that is a lymphocyte / plasma cell should probably at least make you think about it.
Yeah.
Okay, 69-year-old undergoing lobectomy for adenocarcinoma, and then this is a background uninvolved lung.
Yes.
Uninvolved by carcinoma.
Uninvolved record, right. So there was a section taken, they actually thought there was a second nodule. Actually, I don't know whether they saw it or not, but there's a, what I wanted you guys to recognize is that there is a granuloma in the uninvolved lung, or that it is not cancer. The outer lung has some emphysema, but that's about it. But when you look at this tissue and you go higher power in the lead, yeah, so the periphery does have emphysema that you should have recognized. But the pathologic lesion here is this granuloma. And I want you to specifically notice that this granuloma has both giant cells and neutrophils. So this picture should make you think of two organisms. If you don't remember anything else from this exam or this particular case, just remember that when you have mixed inflammation, there are two organisms to think of. And you should know what those two organisms are because you want to order the right stains and look at them. So the two are blasto. Blasto has this very characteristic look of having neutrophils within the granuloma. And the other is nocardia, will give you also mixed inflammation, but nocardia tends not to have such a distinct granuloma. So I would not have thought nocardia in this patient. They tend to have small granulomas, not this large one. And then here, so the stains that you would order, you would recognize the granuloma. You're supposed to order AFB-GMS since we do both together. And actually, even on H&E, you should have been able to see this fungus. And I think it makes a very nice contrast to the colon case that you just saw, because these organisms are much larger than those, and they are thick-walled, right?
Where did you see them on H&E?
Huh?
Oh, like, oh, there. Like
Yeah,
that?
they're within the macrophage, they're within the giant cells, right? So thick-walled yeast forms with some structures inside, and occasionally you can even see the bud. I can see that up there. So blasto should be at the top of your list. If you can't say exactly what the organism, at least you should be able to recognize that there are organisms there. And then on the GMS is really beautifully shows you many, yeasts. They do vary a little bit in size because some are younger, some are older. And so as they divide and the daughter cysts are smaller, but then they grow to the large size, which is about 12 microns or 14 microns. They are very thick walled, and they should have broad-based buds if you can find them. But you can call, as long as you call them budding yeast consistent with blasto, that's good.
Cool.
Okay, yeah,
That's
nice.
fun.
There they are.
My fun.
Yeah, that is a good bud, but it's a little one. Yes.
Cool. Thank you.
Okay. Thank you. Any questions?
We can go with Yasan or Bennett. Any preferences?
I can go whenever, no preference.
Okay, well, since you spoke up, you're gonna go now.
Okay.
Do you want to drive?
Yeah, if that's okay.
Yeah.
Okay, so for this case, a couple important things from the history. 27-year-old with a history of ALL, status post stem cell transplant, complicated by GVHD and tongue squamous cell carcinoma. Undergoing colonoscopy, they found 7 polyps, which varied in size, with the largest being 2 centimeters. And then, so overall, you got 1 polyp for review. So a couple things about the clinical history. One is recognizing that the patient is quite young, especially to have so many colon polyps. He has a history of 2 malignancies, one of which is ALL and the other is tongue squamous cell carcinoma, with tongue squamous cell carcinoma also being quite unusual for a patient of this age. Another thing from the clinical history is that he's status post stem cell transplant. So whenever you see this and you have any sort of specimen, you should think, okay, this patient is immunosuppressed. So think of all the possible complications that can go with that. And there were several polyps. So let's look at the histology. Oh, sorry, I'm just having a hard time.
Oh, go to the next slide.
Oh, okay.
There you
Oh,
go.
there, thank you. So just a couple things from low power. Let me get this into a better focus. So it's a pretty sizable polyp. At low power, You can see the background colonic mucosa over here where the ink is. And when you compare the background colonic mucosa to this polyp, you can see that the epithelium is pretty hyperchromatic. It has pseudo-stratified pencillate nuclei. So you can put it into the adenoma bucket. Overall, at low power, it has both a tubular and villus component. So it's a tubulovillus adenoma. So that's diagnosis number one. And a lot of times in real life, we get, one diagnosis, and we move on to the next case. Hopefully for this case, since it was on the exam, that just wasn't the only diagnosis. So when you go high power and look at different areas of the polyp, you can see that here, it's throughout the polyp. Here's one right here. I think there were a couple more right here. These are beautiful ones. In addition to it being a tubulovillus adenoma, you also have very nice CMV inclusions. These were found throughout the polyp, both within the stroma, like you see one here in the stroma, as well as in the epithelial component. Oftentimes in these colon, any GI specimen, it's more common to see it in the stroma or the endothelial cells or the macrophages, but you can also see it within the epithelial cells as well. Classically, you have these intranuclear inclusions. You can see some margination of the chromatin, classic owl's eye appearance. Do you mind if I go ahead and share my screen? I just have one other teaching point.
Yeah.
Hold on for 1 second. I'm just trying to get it started. Do you see my presenter mode? Yeah, okay.
Yes.
Hold on for 1 second then. I'm just going to show the regular PowerPoint. Is this better? Yeah, okay. So just in terms of the actual endoscopy pictures, they all look like polyps. They're easily recognizable by a pathologist. They're quite large. In terms of just reviewing adenoma classification, as you recall, tubular adenomas have mostly a tubular component, more than 75%. Tubulovillus adenomas, you want 25 to 75% villus component. And villus adenomas being the most rare, you want more than 75% villus component. And just remember that in order to call something a villus component, the villi should be at least 2 times the normal mucosal thickness. So CMV in the GI tract, we saw some nice examples of it in this case. It occurs in roughly 10% of immunosuppressed transplant patients, and we have these classic owl's eye intranuclear inclusions. And classically in the GI tract and elsewhere, it's mostly endothelial, mesenchymal, and macrophages, but you can also see it within epithelial cells. So we usually see CMV in the GI tract most commonly in our immunosuppressed patients. We often see it as well in our IBD patients, more commonly UC versus Crohn's disease. And we can rarely see this in immunocompetent patients as well. So the last teaching point was being able to use the clinical history and diagnosis to offer additional insight and screening recommendations to the clinical team. So therapy-associated polyposis is a recently recognized entity, and it's long been recognized that any sort of radiotherapy or alkylating chemotherapy is associated with a risk of developing GI tract neoplasia. And this study examined therapy-associated polyposis and classified patients as those having at least 10 GI polyps over a lifetime incidence in both the upper and lower GI tract without a known causative germline alteration. There were a variety of childhood-associated cancers in these patients, and overall GI tract polyposis was detected at a median average of 27 years after their treatment. And many of these patients fit the criteria for being put into other polyposis diagnoses. So for instance, 53% of these actually met the criteria for attenuated FAP. And so when looking at this graph, you can see that both the histology of the polyps, and these are just the colorectal polyps, both the histology and number of polyps varied greatly. And it just highlights that multiple diverse biologic pathways are likely implicated in therapy-associated polyposis. So just going back to our case, key points were recognizing it as a TVA, calling CMV, and then with a diagnosis of CMV, you want to make sure that you send the clinician an email or page them, let them know, since it is an unexpected diagnosis. And then to put in the comment that the patient may benefit from referral to the cancer risk clinic for additional workup. And for this patient, he is being seen in that clinic in July of this year. Any questions?
Awesome. Thank you.
Thank you.
And then guess it's gonna be this one.
Yep, I can go. Do I? Okay, yeah. So I know this is a hard case, but once you've seen one, you have a good chance of recognizing it in the future, and you definitely don't want to miss this entity. And it's a classic board question as well. So this patient is an 18-year-old female with an ovarian mass. And the first question was, what is your diagnosis or a differential diagnosis in order of likelihood? Oh, do I have to go to the next slide?
Yeah.
Okay, so we can see here we don't have your normal ovarian parenchyma at all. We can see on the left there's some tumor cell necrosis, and it's a very hypercellular blue mass on low power appearance. We can also see, zooming in here, these cystic or follicle-like spaces. This is very classic for this entity. Normally, they have some eosinophilic material within them. Occasionally, it can be a little bit more basophilic, but I think this is still eosinophilic, yeah. So you have that, and otherwise, you basically just have these sheets of tumor cells. It might be a little bit more nested or corded here, but overall, pretty diffuse sheets. This area, you have more cytoplasm in the cells. You have kind of this clear to somewhat eosinophilic cytoplasm, but the bulk of the tumor, zoom out, has these small cells with basically minimal minimal cytoplasm. You can see there's a lot of nuclear atypia with these prominent nucleoli, burst mitotic activity here. Let's see. What else is characteristic? A few little more nest over here, and you do have more abundant cytoplasm, as we talked about before. In some areas, it's a little bit more eosinophilic. I think in a few areas, it might even be a little bit rhabdoid appearance. I can't remember if this particular slide had it or not. So the main things that oh yeah, here's some rhabdoid appearance. So the main things you think about when you see a tumor in a younger patient that has these follicle-like spaces, the main entities that come to your mind would be a small cell carcinoma of hypercalcemic type or juvenile granulosa cell tumor. So juvenile granulosa cell tumor usually does not have this brisk mitotic activity, although like a subset of about 10% can be briskly mitotic and show anaplastic features, but all in all, it should be relatively bland appearing, and all the cells should have moderate to abundant eosinophilic cytoplasm, which we're only seeing in this area over here. So the diagnosis for this case was small cell carcinoma of hypercalcemic type. And the additional questions I asked were what immunostain would clinch the diagnosis. And this next one is SMARCA4 or BRG1. And in small cell carcinoma of hypercalcemic type, there should be loss or decreased expression. So here we can see the darkly staining cells are lymphocytes, maybe even a few vessels, but you can see the tumor cells, the staining is markedly decreased compared to your internal controls. Sometimes some areas I think showed some better loss of expression, but either loss of expression or decreased expression compared to the controls is diagnostic. And the other question I asked was, what serologic finding can you see in these patients? And the correct answer, of course, is hypercalcemia, which is seen in about 2/3 of the cases. And so the SMARCA4 loss and hypercalcemia are not seen in juvenile granulosa cell tumor, which helps with the differential too if you were given that information from the beginning. And these used to be very aggressive, and they still are very aggressive, but with the advent of EZH2 inhibitors, I think there are clinical trials to help treat these patients, since most of them are so young when they're being diagnosed with this horrible disease. Any questions?
Cool. Awesome. Thank you. Okay. Am I the only one left? Okay. Yeah, I think it's like after you start knowing what these chromatin remodeling complex types of tumors look like, they really have shared morphology. And I think those kind of rhabdoid cell, larger cell areas are really, really interesting, really kind of crosses tumors. Okay. So this is a 49-year-old with a thyroid nodule undergoing thyroidectomy. What is your diagnosis, special stains, and bonus, what clinical workup is indicated? So you can see on low power, this thyroid, there's a relatively circumscribed nodule. And don't let that fool you in thyroid, right? Because circumscription or not, some things can still be malignant, and this is one of them. And so you really don't see any follicular architecture, any papillary architecture. You really just see these sheets of cells. And what makes them different from follicular epithelial cells of thyroid is that they have this abundant kind of granular cytoplasm. They're arranged in more of these solid sheets or nests. And, arguably, the nuclei, although in areas they may be cleared and resemble papillary carcinoma, they are quite kind of salt and peppery, kind of like speckly chromatin, which is what you'd expect in a neuroendocrine neoplasm. So the growth pattern, the cytoplasmic granularity, and the nuclear stippling should point you to at least make you think about a diagnosis of medullary thyroid carcinoma. There are a few other things that we see in medullary include kind of some of this random endocrine atypia with some of these larger, kind of more wonkier or bi or quadrinucleated cells here. Medullary can actually on rare occasion have inclusions, or at least inclusion-like cells. And then, this pink stromal material in the background that should at least raise the possibility of potential amyloid. And so if you wanted medullary at some point, you got, if not full, at least partial credit if you had it in your differential. The way that I graded these things was if you listed the thing first in your differential, you basically got full credit for it. So there's some, qualification of sort of prioritizing your differential. If you had it in there at all, you at least got partial credit. And so this is calcitonin, and this is Congo red, and there is at least, oh yeah, there are at least a few areas here where you can see some red being uptaken. And so this is positive. And as you guys probably already know, this material here is actually cross-linked calcitonin proteins that creates the amyloid in the background. The workup in this patient, yes, they have high serum calcitonin levels, but that's kind of almost a given. What really is indicated is if you said germline or tumor or germline testing for RET mutation, generally we start with the tumor. If the tumor has a RET mutation, then they go and test the germline. Even in adult patients, even in otherwise potentially sporadic medullaries, some of them actually pick up underlying germline RET mutations and can actually be diagnosed with a syndrome. So more and more now, we are basically testing pretty much all medullary carcinomas for RET. And again, if positive for RET mutation, then the patient's germline is tested. So that's kind of the indication in this patient. Questions? Okay, and then the other one was a BST case, which is a male with excision of thumb mass. And you can see that it's sort of multilobulated, or at least serially sectioned, giving the appearance of multiple lobules. Generally, in this tumor can be seen in small joints of fingers. It can be seen in large joints. And what sort of may clue you in is the very cellular monotony here in the background, without much atypia and or mitoses. Occasionally you see a giant cell, but you don't have to see abundant giant cells in this tumor to be able to call it what it is, which is a tenosynovial giant cell tumor. As with most giant cell rich lesions of bone and soft tissue sites, the giant cells are bystanders, and the lesional cells are these background mononuclear cells that have kind of histiocytoid appearance with grooved wrinkled nuclei. And if you're lucky, you may see foamy kind of xanthomatous histiocytes. Oh, maybe, no, that looks like myxoid change. Maybe there's a few foamy histiocytes. If you're lucky, you may see hemosiderin, but really, though the histiocytes, the hemosiderin, and even the giant cells are not necessary to make the diagnosis of a giant cell tumor. Really, the neoplastic cells are this monotonous monotypic histiocytoid cell population. So there was a lot of, number of you got it right away, and then some said some interesting other malignant diagnoses, which in this case would not have been correct. You know, tenosynovial giant cell tumors localized type are basically a near equivalent to tenosynovial giant cell tumors diffuse type, which carpet the larger joints, which would otherwise be referred to as PVNS. We no longer use PVNS diagnostically, but you know, conceptually pigmented, so hemosiderin, villonodular, right? Synovitis, meaning it lines the synovium. This case would be a single nodule kind of like stuck on the tendon, usually of a smaller joint, rather than carpeting the joint. The difference is that these are much easier to excise and less risk of recurrence than the PVNS type of lesion, the diffuse type, which is difficult to excise and much more clinically, locally, you know, potentially aggressive. Okay. And no questions in the chat. And then the last one, kind of a generic ENT case, 15-year-old male with nasopharyngeal mass. And you can see a few things. One is it is richly both kind of collagenous fibrous and vascular with these slit-like blood vessel spaces. In areas, there's a little more cellularity in the background, but still the cells, the fibroblasts, are relatively bland with small nuclei, not really significant hyperchromasia or atypia. And you know, in a teenage boy with a vascular rich lesion, you should really focus on, you know, honing down your differential to a few things. One of them, which is this, is a nasopharyngeal or so-called juvenile angiofibroma. These are related to the Wnt signaling pathway. So they have nuclear localization of beta-catenin, which can be helpful in differential diagnosis as opposed to just a pyogenic granuloma or something like that. They also have androgen receptor positivity in the nucleus, so perhaps one of the reasons why they are finely sensitive in adolescent boys. And lastly, these are extremely bloody, right? So these kids generally present with nosebleeds, and one of the things that happens preoperatively is they undergo embolization, and so sometimes you can actually see this amorphous eosinophilic embolic bead material in the vessels, and so that's you may assume that they underwent embolization, but in this case you could actually see it, and it resulted in maybe a little bit of downstream, maybe a little bit of degenerative change or necrosis. But if you said that you saw the embolic beads, that was your bonus point. So that I believe that was all of the cases. If you want to know how you guys all did as a kind of a group, I could certainly show you that. And I can go over how I did the grading if you want, but I'll do that very briefly since we're over time already. So this, make sure I share, yeah. So, as I said before, if you said something first in your differential, you essentially got full credit for it, or partial if it was down on the list. If you're very, very interested in the grading, I can, send you exactly how we did it. But for the ones with bugs, if you called them granulomas only, without the special stain, I gave you half credit. If you called the special stain only without calling them granulomas, I also gave you partial credit. Kind of things like that. And then the ones with multiple questions were kind of broken down into multiple parts. High score, this exam was 95, so great job. And this is the breakdown of PGY 1, 2, 3, and 4 over time. So, pretty standard, no real significant outliers in the average, in the aggregated groups. So, got any other questions? I hope you guys learned some things, and in the next, as usual, be ready for 6 months from now. So like November and May are our general months of the exam. I am hoping in the future to be able to transition a lot of the exam to Dr. Yasan, who has graciously accepted to kind of transition some of this over to her. So always, it will be a collaborative effort from many attendings, but we'll work together and transition it over to Lindsay.
I'm excited.
Yay. Cool. Any feedback is welcome. Thank you guys very much.